I've met a lot of you earlier today. For people who haven't met me, my name is Sarah O'Brien. I work at Nationwide Children's Hospital in Columbus, Ohio. So probably your first question is, why is a pediatrician standing at a microphone to talk about later life care for women with bleeding disorders? So I think reason one is because there's a huge need for this topic as evidenced by the number of people in the room. Number two, we have a very small number of people in our field who will talk about this. And I'm also a people pleaser. So when Heather said we really wanted to talk on this, I was like, I'll do it. And I also had a really neat opportunity to write a paper last year with Dr. Ariel Langer from Harvard, who is an adult hematologist. And we wrote an article about the whole reproductive lifespan for women with von Willebrand disease in particular. And so that was a really neat experience for her to learn from me, for me to learn from her. So a lot of my practical tips are coming from what Ariel typically does for her patients. And as we talked about this morning, some of the information here we'll have seen on an earlier slide if you came to some of my earlier talks, or it may have come up in discussion. So sorry in advance for anything that's repetitive. I think what we were focusing on in one of the discussions this morning is how it's important to not lose our patients with bleeding disorders over the years. So I know as a pediatric doctor, what I see sometimes is my patients are great about coming to see me, but then when we transition them to adult care, life gets busy. Maybe they went somewhere else for college and they just lose that contact with the hematologist. And then they may re-enter hematology when they are pregnant. Hopefully they're re-entering hematology when they're pregnant. But then after women are done having their children, they may lose us again. And I think we don't do as good a job as we should counseling ahead of time that this may be a time of your life where your bleeding disorder does impact the symptoms that you experience as you go through perimenopause. And I think also, just on a personal note, I am 52 years old. I've been through menopause. I was lucky to have an OB-GYN who was excellent, but a lot of my friends have not had that experience. And so I think just the more attention we can give to this, the better. Um, so I think particularly when we're talking about the perimenopausal years, what we want to talk about is to help our patients anticipate that their bleeding patterns are likely to change as they approach menopause, and something that may have worked for years for them may not work, and they need to come back and see us, or we may need to consider other reasons for heavy menstrual bleeding. And we'll also touch on in this talk how this is still an important time of your life to be considering about iron deficiency. Okay. Heather also wanted me to touch base on sexuality, which is really easy because there's nothing out there. So I found two studies that I thought were relevant to this group that I'll review with you. What made me feel a little bit better was that both of these studies were from 2025. So that makes me think that like people are starting to get interested in this. And I think the quick points about the two studies are one, yes, this affects sexuality, and two, we know some of the themes in which it affects sexuality. So this is a study from the WIN study from the Netherlands that has been a really great study for von Willebrand disease in general. And this particular study was asking questions about how bleeding disorder relates to sexuality. So I think what you can see from this slide quickly is that women with von Willebrand disease reported many more concerns with sexuality than men with von Willebrand disease did. So about 10% of the women with von Willebrand disease did consider this to be an issue. And it could be an issue in different ways. There could be pain, joint problems. Heavy menses was a big one, and we'll talk about that a bit more on the next slide. Fatigue interfering, they're iron deficient, they're fatigued, they don't feel like having sex. Maybe a medication they're on is doing something with their interest in sex. And then maybe from other bleeds that they're experiencing or bleeds during sex is impacting their sexuality. This study was from another group of investigators who were looking at a small number of women. I think there were about 30 some women in this study, but these were women with a whole variety of different types of bleeding disorders. And they did interviews with these women about a lot of different facets in life. I'm going to focus on sexuality and intimacy. But when people do qualitative research, we're always looking for themes. Like, what are the things that keep, we don't, these are usually structured but pretty loose interviews. We really want to hear like what the patient is saying. They're not multiple choice questions or things like that. And then they look to see what themes are coming up naturally over and over again among this patient population. So, one of the first themes that was identified was feelings of insecurity. And a lot of this centered around women having concerns about participating in sex while they were having their menses in particular, because they felt like their menses were heavier than others. Like, would they pass a clot during it? Would their partner, think something was wrong? So that tied into a lot of it. Um, Number two was communication with healthcare providers. And the common theme, which probably many of you can relate, is that we as healthcare providers don't bring this up enough in our visits. And it can be something that's uncomfortable for a patient to bring up on their own. So they felt like it wasn't a topic that was raised in their annual visits. And they also felt like if they talked about it, that maybe their healthcare provider got uncomfortable. Number three was easy bruising and bleeding during sex. So I think that, not wanting their partner to see their bruises, like especially in new relationships, like what would they think if they saw these big bruises on my thighs? Or some women may experience bleeding with penetration. I think this is something that I try to remind myself as an adolescent young woman doctor to talk about, because not only one, letting patients know that they might experience bleeding with sex, and to let me know if that's becoming problematic, but also on the other side to let them know that if you suddenly start bleeding with sex, that's not normal and you need to let me know. Like, don't just automatically attribute it to your bleeding disorder. So, for example, one of the things we think about with bleeding during sex is, could somebody have a sexually transmitted infection? So that would be something we would want to test for before just contributing it to somebody's bleeding disorder. As we get older, bleeding during sex could mean that there's a difference that's happening with the cervix, and that's also something that we would want to explore without just blaming it on a bleeding disorder. Partners' understanding and support was, of course, important. And this was on both sides, like wanting their partner to be supportive, but also on the other end, not wanting a partner to feel like they had to be extremely cautious with them or put them in a bubble, or be nervous about having intercourse. And then the last one was about disclosure about the diagnosis of a bleeding disorder. And, is that something you bring up on the first date? Is that something you bring up before you have sex? Like, when's the right time to talk about that? So these are kind of the themes that patients brought to the forefront that they think about in this topic. So my goal with this talk is to go through a few different patient scenarios, and we'll talk about hormones, of course, but we'll also talk about some of the other things that we have to consider as our patients get older. So, for example, bone health is a big issue in bleeding disorders, so we'll talk about that a bit, and we'll also talk about how we have to think about planning for surgeries differently as our patients get older, and in particular, how do we plan for surgeries, if our patient has had a heart attack and needs a stent, or a whole different host of disorders. Okay. So our first patient today is a 45-year-old woman who is a symptomatic person who carries the factor IX gene, and she's had a long history of heavy menstrual bleeding. Um, her her periods have actually been well controlled, particularly in the last 10 years since the birth of her second child. But over the past 9 months, she's noticed that during her placebo week of her pill, she's having worsening heavy bleeding and more cramps, and also some hot flashes. She's also reporting this new feeling of pelvic heaviness and is experiencing fatigue and decrease in exercise intolerance. So, of course, whenever we hear that you are fatigued, we always want to make sure that your iron levels are in a good spot. So, we check labs and find that the hemoglobin is 10. Um, do people remember what the normal hemoglobin is for women? 12. But you're right. Who said 30? 30 is the normal ferritin level for women. So, this patient has a low hemoglobin and a low ferritin. So we showed this slide earlier today when we were talking to our youngest patients because we were talking about anovulatory bleeding. And I was explaining how during the first few years after you start to have a period, it takes a while for the hormones in your brain to learn how to talk to the hormones in your pelvis and vice versa. And you can have more irregular, heavy periods during this time. But then what happens as we reach perimenopause is that those communication chains start to break down and our hormones forget how to talk to each other. So this is another time period where bleeding can be heavier or more irregular. And there's been a few studies in the literature that interview women with bleeding disorders at the end of their, like after their reproductive years. And it's very common for women to report that when they think back, they definitely struggled the most with heavy menstrual bleeding in the first few years after they started and in the last few years before they ended. So it's important that we counsel our patients so that they are expecting this. However, it is just as important that we do not just blame any new bleeding on an underlying bleeding disorder. And that's because as we get older, the causes for heavy menstrual bleeding change a lot. And the structural causes of heavy menstrual bleeding, the likelihood of those go up a lot more. So we start to see fibroids, we start to see polyps, we start to see endometrial hyperplasia or cancer. Those are all reasons why women may start to bleed during midlife. And so the recommendation is that any new or worsening bleeding in middle age should require collaboration with gynecology. So you need to make sure both your hematologist and your gynecologist are aware and that they're working together to figure out what might be going on. Certainly, a woman with fibroids who has a bleeding disorder may bleed more than a woman with fibroids who does not have a bleeding disorder. So we're still helpful as hematologists to help manage the treatment, but we want to make sure we're not just assuming that it's the bleeding disorder that's the only cause. Yes. 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 So we were talking earlier today. I mean, the ideal care for all of you, right, is a clinic where you're going to see your hematologist and your gynecologist at the same time. And we do have clinics like that throughout the United States. We were talking about how the Foundation for Women and Girls with Blood Disorders actually has a map where you can see where these clinics are located. Unfortunately, most of those clinics are still pediatric clinics. There's much fewer adult clinics available. And I think that's due to logistical reasons. I mean, this is a joking way to say it, but in a pediatric hospital, like none of the physicians are making a lot of money. So we're very happy to work with each other. And the gynecologists are happy to come to our clinics and vice versa. In the adult world, the medicine department is very different from the OB/GYN department. So, borrowing a gynecologist to come over to an internal medicine clinic just involves a lot more logistics and billing hurdles than we experience in pediatrics, unfortunately. But I think it's still, we talk a lot about this at the Foundation for Women and Girls with Blood Disorders, that those of us in adult hematology who don't have these clinics still need to make an effort to connect with a few gynecologists so that we can send our patients to them over and over again, and they start to learn about our patients and the special care that we need. And this is definitely a situation where we need to pick up the phone. And your hematologist should definitely be willing to pick up the phone and talk to your gynecologist. And that's the only way these collaborations happen sometimes. Yes. Oh, it's the gynecologist. Hmm. Yeah. I think it's definitely a different experience. I think those of us in hematology become more of a primary care doctor for our patients. And I think that's what happens when you're often caring for a family, not just one patient. And I think that it's definitely a different model. You know, OB-GYNs are surgically trained, they're procedure oriented, delivery oriented, but sometimes you do have those challenges. I hear you. Did you have a question or comment? Mm. Mm-hmm. I think it totally depends on who your PCP is. There are some PCPs who are very comfortable with reproductive care and very knowledgeable in that area. Some of them have even done special training in women's health. So it's definitely possible that there are PCPs that could be providing excellent care. But if you have any concerns that they don't seem to be putting all the dots together, then yes, there's not a certain age where you shouldn't stop seeing a gynecologist. Okay. I'm going to go through this part quickly because I know some of you heard it before, but it's so important that I want to make sure that people who weren't here see a little bit of this. So, we were talking about the very close relationship between heavy menses and iron deficiency. We were also talking a lot about how there's still this misperception that iron deficiency without anemia does not matter. We were talking about who, you were the one who donates blood, right? Was that you? You're right. Right. So we were talking about how somebody went to donate blood and they were told their iron was fine because they pricked their finger. And we were making the point that they're not checking your iron, they're just checking your hemoglobin. You could be iron deficient and have a normal hemoglobin. So we need to be more specific about the language we're using. And that iron doesn't just build red blood cells for us, but it affects many different organs in our body, in particular our musculoskeletal energy, our brain energy, all of these are affected by iron deficiency. We talked about how these are some of, not all, but some of the most common symptoms of iron deficiency: fatigue, shortness of breath. For me, you know, my athletes will notice that they don't have the same swim times or cross country times that they used to have. They might experience leg weakness, headaches, difficulty falling asleep or restless legs, poor focus in school, heart palpitations. We talked about how some women experience hair loss with iron deficiency. Others may feel cold with iron deficiency. Some might have thin nails with iron deficiency. And I think a lot of these symptoms can be dismissed as like, you know, oh, you're pregnant, so you're tired. Oh, you're a busy mom, so you're tired. You know, even so far as, you know, one of my colleagues talked about this and it blew my mind. And she said, we always talk about how girls aren't as good in math at school as boys are. And she's like, is it because girls have just been iron deficiency in high school for years? And so they're just not, they're struggling to concentrate. So it really, I think, blows your mind when you think about all of the impacts that iron deficiency can have on us. We talked about how there are finally recommendations coming out from the American Society of Hematology on what should the definition of iron deficiency be. And I'm thrilled that somebody was listening and remembered that the number was 30. So that is the ferritin number. We talked about how ferritin is the lab you want your doctor to be checking because ferritin shows your iron stores. You don't want your iron level check that just says what your iron level is at that moment in time. Maybe you had a steak last night. Like it's just not as informative. So every woman with, I would argue every woman, but especially every woman with a bleeding disorder should be having their ferritin checked at all of your annual visits, even if you're not having a particular bleeding concern at that visit. Say that again, please. They don't have an official, then that would be in the general adult population, which the number is still 30. So they made it easy because all of their recommendations for menstruating individuals, general adults, and pregnant individuals is all 30. So you just need to remember the number 30 for the rest of your life. We also talked earlier today about how less is more when it comes to oral iron. You don't want to take oral iron more than once a day. Your body will not absorb it as well. We talked about how every other day works just as well, but can be very helpful to avoid some of those GI side effects like nausea and constipation. Um, I personally find every other day very hard for people to remember unless they use a pill box. So I'll often suggest like picking Monday, Wednesday, Friday, or picking the days that you have soccer practice, like some anchor to help you remember that you should take your iron that day. And finally, we talked about how IV iron is becoming more and more commonly used in our field, which is great. The newer formulations that we have today are much safer and better tolerated than the old IV iron of the past. And really, if somebody is symptomatic, in my mind, we should be starting oral iron, rechecking labs in 6 weeks. And if we're not making any progress or you're not able to tolerate that oral iron, we need to think about IV iron. Um, we haven't gotten insurance companies up to speed on where we want to be with IV iron, so we still definitely struggle with arguing for on advocating for our patients with their insurance companies about IV iron, and in particular the types of IV formulations that we use. Sometimes the insurance companies want us to use the ones that aren't our favorite because they are less expensive but require more visits to complete the therapy. So but just to have that in mind, if the oral iron is not working for you or you're not tolerating it well, to ask about IV iron. So coming back to our patient, so for this patient, we already discussed how she has iron deficiency anemia. Her hemoglobin is 10, her ferritin is 5. That's well below where we want her to be. So we'll start oral iron supplementation with ferrous sulfate, and we'll have her come back in 6 weeks to see how that's working, both from a symptom perspective and from a lab perspective. In terms of her heavy menstrual bleeding, when somebody is experiencing new feelings of pelvic heaviness, we should be thinking about things like fibroids. So we would definitely want this patient to go see gynecology. So in this case, she was diagnosed with fibroids. She decided to have an IUD placed, which can be quite helpful with, it doesn't treat the fibroid itself, but it helps to greatly decrease the bleeding from the fibroid. And the plan was to do the IUD. If that didn't help sufficiently over the next several months, then she was going to consider having a hysterectomy done. Yes. I put that because of her levels, but yes, if I think that's still confusing in the nomenclature about whether, like right now, the ISTH recommendations are for a factor level of under a certain amount called hemophilia, but I think that there's a lot of I don't like the phrase symptomatic hemophilia carrier. And I think that, in my opinion, we should broaden that. And if somebody has a clinical phenotype of bleeding, we should just say hemophilia. So what I'll sometimes do with these patients is I will start the oral iron and then we will begin the insurance process for the IV iron at the same time. And then that way, once the authorization for the IV iron comes back, we just check in with the patient. Sometimes they're like, oh, I'm feeling better, let's hold off. Sometimes they'll be like, no, let's just do the IV now, because it can take several weeks to get all the paperwork back. But you're right. If somebody is very symptomatic, then sometimes we move straight to IV iron. Mm. Hmm. Yeah. Yeah, it's hard. Yeah. I have had patients with like major allergic reactions to something, and it's still hard to get the insurance company to change their mind. I think the other point about IV iron is that the other reason why women may want to do oral first rather than right to IV is that I always counsel my patients i- insurance saying they will cover the medication does not equal insurance is paying for the entire medication. And IV iron is quite expensive. It costs a few $1,000s. So even once approved, you want to make sure that you're understanding from your insurance company how much your out of pocket pay would be for that. So that impacts patients' decisions. You know, sometimes I'll have patients who say, "We already met our deductible this year, like IV iron, like for everybody." And sometimes it's January and they're like, let me try the oral iron for a few weeks and see how that works. Mhm. 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 It's also worth checking out. I know Injectafer, for example, I think some of them have a patient program too, where the patient can apply. We can't do it for them, but the patient can apply for assistance. Yes. Good point. Thanks for bringing that up. The next patient I wanted to talk about is a 48-year-old woman who has von Willebrand disease, and she hasn't seen hematology for a while since she finished having her kids. But she's been having some worsening anemia and is sent back to hematology. You also learned during this visit that she did have severe delayed postpartum hemorrhage with one of her two deliveries. So she had had adequate control of her menses for years with oral contraceptives, but once she turned 45, her gynecologist told her she had to stop her oral contraceptive because her risk of thrombosis was too high. So you're able to dig back to find her old records, and you find that her labs when she was in her 20s show a factor of von Willebrand factor of 38 and an activity of 40 with a normal factor 8 level. You check her labs again at this visit, and her levels are in the 50s. So she is considering hysterectomy for definitive management of her heavy menses, but her gynecologist wanted her to see you before the surgery. So this case brings up a few different things we have to consider when we're caring for, you know, a new patient who has come back in her 40s. Yeah. So her numbers when she is in the 50s are now normal. A level of, thank you, a level of 50 or above would be considered normal. But we're going to talk about how we can't make that assumption with a patient like this. Did you? Right, right. But this is the case where you're like, thank goodness that the gynecologist told her to come to hematology, because if the gynecologist had just rechecked their levels and they aren't flagged in the computer as abnormal, you know, a less knowledgeable provider about bleeding disorders may have been like, oh, you're fine, you don't have it anymore. So we already talked a little bit about this, but just the importance of kind of counseling. And a lot of people don't even know what is perimenopause and what is menopause. So the definition of menopause is that you have had 12 months in a row without experiencing a period, and it's in the absence of other reasons why that might be happening. And then perimenopause is kind of those years leading up to that final the 1 year after the last period. 90% of women will experience that menopause between 45 and 55 years of age, and the average age of menopause is 51 years. So I think what we think is that, you know, the menses will just kind of like go off into the sunset. And unfortunately, that doesn't happen a lot for women with and without bleeding disorders, but particularly in women with bleeding disorders. Another common misconception is that we don't have anything available to help with this, and that it's just kind of a grin and bear it situation until you're done with your periods or until you have a hysterectomy. So hopefully we can dissuade both of those. So, um, so what we think of is that we all therapies for heavy menses have some place for the emergence for heavy menses and perimenopause. So it was inappropriate for this patient to be told like on her 45th birthday that she couldn't take oral contraceptive pills anymore. You have to take each patient into consideration and look at whether they have other risk factors for thrombosis at that time. Are they a smoker? Do they have high blood pressure? Do they have diabetes? Do they have other risk factors? Are they extremely obese? Like those are all other things that would make you less comfortable for a woman in her 40s to be using an estrogen product. But we also have progestin only options like we talked about earlier today. So the point here is that she shouldn't have just been, it should have been a discussion. Like here we are in the mid 40s, let's talk about the options. Here are the risks and benefits of keeping on with what you're doing. Here are the risks and benefits of trying something different. Women definitely think about hysterectomy sooner when they're in this time of life because they're not planning on having more children. So we do get more consults, and whereas with my patients, if somebody's telling my 25-year-old that they need to have a hysterectomy, I am definitely saying no, that is a terrible recommendation. So this is different when we're talking about someone in their late 40s. The other thing that a lot of people don't recognize is how long perimenopause is. So this lasts for an average of 5 years. So you don't want to grin and bear it for 5 years. That's a long time. This case also brings up the issue that we know that von Willebrand levels increase with age. And after age 40, we think they go up about 10 points per decade. And so for patients with type 1 disease, this means that a fair amount of them will have normal levels when they become older adults. And this becomes important because as an older adult, you're more likely to need a surgical procedure. Or a procedure such as a colonoscopy, like other reasons why you might need a surgical plan. But just like this morning, if you remember, we were talking about how we don't know what an appropriate von Willebrand or an appropriate factor level is in the third trimester of pregnancy before you have a baby. It's the same here. We don't know what the appropriate von Willebrand level you need at age 60 to undergo a surgery. If the whole population's von Willebrand levels are going up, then the patients with von Willebrand needs to have higher levels also. So Dr. Langer talked a lot about this, and her recommendation is, then this is what I do for my patients in their 20s who maybe are now having a baby and their levels are higher than they were when I was taking care of them. But we err on the side of caution. And so for a patient like this who's just entering the normal level, she's in her her levels are in the 50s, and she has a known history of bleeding. If you remember, she had a severe postpartum hemorrhage. So she has a significant bleeding phenotype. We would definitely recommend factor support and hemostatic support for this patient. On the other hand, Dr. Langer's personal practice is if the levels have increased over 80, then she's more likely to do a wait and see approach with the procedure, like have something ready to go if there is bleeding, but to expect that they'll probably do fine with that procedure now that their levels are in the 80s. You also brought up the important point that you have to keep in mind what's happening at the time that you're checking those levels. Are they on an estrogen containing pill that's raising their levels? Are they pregnant and that's raising their levels? Were they an hour late for the appointment and they're running in breathless to get their blood drawn? Like all those things are going to increase your von Willebrand levels. So for this patient, she's referred back to hematology primarily due to the anemia that she's developed, but it's a good thing that she came because we have a lot of other things that we can add to the picture for her. So after reviewing the risks and benefits, it was decided that it was safe for this particular patient to go back on her estrogen containing birth control pill. She did that, but it wasn't working as well. So then we had a discussion about whether to try the IUD, maybe with some tranexamic acid. But she decided that since she was definitely done with her childbearing years, since she knew she had several more years of this to deal with that she decided that she wanted to do a hysterectomy. And so for Dr. Langer, given that her levels had barely normalized, she gave this patient factor support during that hysterectomy, and things went very well. The last patient we'll talk about before we talk about bone health this is a woman in her 60s with mild hemophilia A. So she has baseline factor levels in the 30s. And she's presented to the emergency room with chest pressure and shortness of breath. So she gets an EKG performed, and the findings of those EKGs and this troponin level that you see here, these are all signs that somebody is having a heart attack. So she needs to undergo urgent cardiac catheterization to open up the coronary artery that is causing this heart attack. Yes. By that, I just say from like what she is at her hematology visits, like in a non-stress situation. Mm-hmm. Yeah. Yeah. So cardiovascular disease and bleeding disorders are not exclusive. You can still have cardiovascular disease if you have a bleeding disorder. It is less common, so they think there's some protective effect of having a bleeding disorder, but it can still occur. I mentioned earlier today that the American Society of Hematology and several other organizations came out several years ago with really helpful guidelines for the diagnosis and treatment of von Willebrand disease. I would say this particular guideline is not so helpful, that people with von Willebrand who require anticoagulation or antiplatelet therapy should receive them. There still leaves a lot of unanswered questions there. And we were talking about this morning, that's because the treatments for cardiovascular disease involve all the medications we tell you that you're not supposed to take, like aspirin and Plavix, and sometimes anticoagulation. So the message here is that sometimes our patients do need these therapies, and we take different things into account to determine whether they need factor replacement in order to safely receive the cardiovascular treatments that they need. So again, we're going back to the hematologist is always trying to balance the risks of bleeding and clotting. So these aren't set in stone guidelines. We still need a lot more research in this area, but I wanted to show this because I thought it would be of interest to people to kind of put your own factor level in there and see what you think. So most of our evidence, of course, comes from men with hemophilia. And so we don't have a lot of data for von Willebrand disease yet, and we definitely need more data in general for patients who don't have severe hemophilia. But at least we know from the evidence from the hemophilia literature that a factor VIII activity level of at least 5% should be is recommended for single antiplatelet therapy. And that typically means aspirin. Usually if somebody's on single antiplatelet therapy, they're on aspirin. The levels need to be higher if you're on what we call dual antiplatelet therapy. And that's when the cardiologist wants you to be on aspirin and Plavix. And those are because those agents work a little bit differently. Or like my patients with congenital heart disease who have to have these types of surgery, they may be on dual antiplatelet therapy for several months after the surgery and then just on aspirin after that. So, but you need higher levels, more like 15 to 30, we think. Yes. Mm-hmm. 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 Right. Yeah. Right. That's such a good point. The other practical thing that all of you should do is, you know, ele- physicians all love and hate electronic medical records at the same time. It's made our job easier in some respects and a lot harder in other respects. But one of the things that I do for my patients is when you're all of you have a problem list in your electronic medical record that lists your diagnoses. Your um, doctor can take an extra step of going into that diagnosis and labeling it as critical. What that does is it, depending on your hospital, puts a red banner under your name or a yellow banner. But what that does is any anesthesiologist will see that. And that can help be a trigger for someone to call a hematologist. Because if you're in the emergency room, like they're focused on your heart attack, the patient is probably feeling terrible and not focused on much of anything at all. And so that's just one practical way. For people who have joint hypermobility, what I do is I also put bleeding disorder on their problem list because bleeding disorder starts with a B, so it'll be at the top of the list. And not everybody knows that joint hypermobility can cause bleeding. And then I label that bleeding disorder as critical. So anything that we can do practically so that I understand maybe you're on vacation and the ER you're at is not where your hematologist is, but anything you can do to make sure your medical record is as clear as possible. So similar levels for von Willebrand are thought what we need to do these antiplatelet therapies. So for this patient, she did need to receive factor VIII before she could be rushed to do the cardiac procedure to avoid what you're talking about. Um, but we do need to use the blood, the cardiologists do need to use those blood thinners. So we have to use heparin during the procedure. You made the point this morning that you or a family member received half dose heparin. So we were talking about how that's the important thing, that shows when what happens when doctors work together, right? When the hematologist talks to the cardiologist. Um, this patient, Dr. Langer, continued factor for several days after the surgery until everybody felt comfortable that she had achieved hemostasis. She needed to be on double antiplatelet therapy for 4 to 6 weeks. Since her baseline levels are in the 30s, we didn't do factor replacement during that. But if she had been someone whose baseline levels were lower, or von Willebrand with baseline levels in the 20s, we probably still would have done some factor replacement during those 4 to 6 weeks. And then after that, she was just on aspirin indefinitely. I think the other thing to keep in mind with aspirin that's off topic to here, but we didn't talk about it this morning, is aspirin is being used more and more in pregnancies to prevent preeclampsia. So, especially my patients who are younger and so at higher risk of preeclampsia, I see this a lot. So, it's just important that when somebody's recommending aspirin, it may be the absolute right idea for you to be taking that aspirin, but you want to make sure they know you have a bleeding disorder. And depending on the levels, you may need some extra support for you to be on aspirin at any time, whether it's pregnancy or in scenarios like this. The last thing I wanted to focus on is bone density, which is an issue for all patients with bleeding disorders. And patients with bleeding disorders, including asymptomatic carriers of hemophilia, have lower bone density compared to the general population. We also know that chronic anemia can be associated with low bone density. So there's kind of more than one thing going on that could contribute to a higher risk of bone density. The last thing is some of our patients experience bleeding into their joints. And there's also been some interesting studies of, quote, asymptomatic hemophilia carriers who had MRI studies showing that they did have evidence of having bleeding into their joints, even though maybe they never had a symptomatic joint bleed. So something for everybody to keep in mind. I think that these recommendations are good for all women, but are particularly appropriate for women with bleeding disorders. So experts recommend routine screening using a DEXA scan. That's like a X-ray machine kind of that measures your bone density for patients with symptoms of low bone density or at high risk. So this would be like around age 40 to 50, depending on the difference in risk factors, but definitely something you should ask your PCP or your hematologist about. When should I start doing regular DEXA screening? We all know that, I'm sure you've seen in your neighborhood, like all the middle-aged women are walking around wearing vests. Has anybody seen that? The weighted vests? Yes, that's because everybody's focused on the importance of weight-bearing exercise. So that can be done with strength training in the gym. That can be done by walking your dog while wearing a weighted vest. So all of those things are great. Um, we also want to make sure that the recommendation is that patients with bleeding disorders should be having their vitamin D checked at your annual visits, and that we act on low vitamin D to help with bone density. Uh, I live in Ohio. We never see the sun. We're at high risk of vitamin deficiency there. So this is something for everybody to keep on their mind as part of your general health screening. And then I think that this is an area where those of us who are lucky enough to have a physical therapist in our HTC, they have expertise in this area as well, or what are the exercises that can be helpful. So these are the particular recommendations from MASAC, which is the general body that provides guidance on patients with hemophilia in particular. So DEXA screening should begin at age 50 for those at increased risk, and everybody here would be somebody with increased risk. If you've had like a low trauma fracture, which means like people who like broke their wrist and it really didn't seem like that should have caused a fracture, or if you have a osteopenia or low bone density on your DEXA scan, should be referred for treatment at a bone health clinic. We already talked about some of the prevention strategies, and I think we need to do a better job as pediatricians to remember to screen our patients for vitamin D deficiency as well, so we can act early and make sure we're optimizing bone density throughout the lifespan. Okay. Well, hospitals will have a DEXA machine though. Like even a community hospital would have a DEXA machine, or there are also like I know of some primary care, like there might be a office building with lots of primary care doctors and they may have a DEXA machine. So it's not like an MRI. They're much more accessible. Yeah, that's a good idea. Yes.
I have a question. So, like in regards to sex and stuff, is someone with a bleeding disorder, when it was talking about like pain and bleeding and stuff like that, is that not normal for other people, like that don't have bleeding disorders?
Tell me more what you mean by pain and bleeding. In what context?
Like from penetration.
So
Is that what that graph was about though?
yes. So that graph was saying that, right. No, I was just, now I'm with you. But yes, so many people experience pain with intercourse for a variety of different reasons. So this was more people talking about having some bleeding after penetration during intercourse.
Only because I have a follow-up. So, for anyone that might experience that or have in the past, this was life changing. I went to a conference. There was like a sexual coach there, and he shared this lubricant. I swear by it. Like if y'all need it, it is on Amazon. It's called Uberlube, and it's
I love
silicone. And I swear, like it is changing our sex life for sure. Like I don't have like the all that pain and stuff like I used to.
That was Uber Lube. So so Heather, at the next Ladybugs meeting, I expect to see an Uber Lube booth in the exhibit center.
No, I mean I'm serious because like the stuff that you get all this stuff in stores and it would hurt like it is not comfortable and then I would bleed and I'm like is this normal? Is it because my bleeding? And
That the
don't use all toys because silicone and silicone don't mix, but you know.
The other thing that happens is when you are going through menopause, your lining down there is more thin, and so it becomes drier and more prone to bleeding. So that may be why it is possible for you to not have had bleeding during sex before, and then it becomes an issue suddenly in perimenopause. So once you have ruled out other causes of that with your doctor, then yes, lubrication is an amazing solution. I feel like that's a high note to end on, but
Anemia, is that classified as low? Ferritin is low altogether. So those are low, that's
yes. So what happens is it's all a spectrum. So you become iron deficient, and then as it gets worse, your red cells start to get small, and then as it gets worse, your red cells start to go down in number. So iron deficiency with anemia is like the severe end of that spectrum, and that means that your hemoglobin was low and your ferritin level is low. That's called iron deficiency without anemia.
the iron thing, that saturation level, is that what you were talking about? Should be 30 or something?
The ferritin. There's also an iron saturation level, but that's also like a 1 point in time test. So that's something that we use when we're trying to figure out a situation, but for general screening, ferritin is what you want. And there's one in the back. I think that, I mean, for most of my patients, the vitamin D by mouth works really well. So if the levels have, a vitamin D level of lower than 30 is an insufficiency and requires like daily vitamin D. If the level drops below 20, we do this really high dose once a week by mouth, and that usually works really well, and it's well tolerated. But if that doesn't work, then that's when you would start to think about other things. Okay, thank you so much.